Hi, this is QD Clinic, and I'm Jack Cush, executive editor of RoomNow.com. QD Clinic is brought to you by RoomNow Live. It's going to happen in Fort Worth and on your computer, streaming live, March 20 and 21st, a day and a half meeting. Be there. Great rheumatologists like us go to great virtual meetings, hybrid meetings like this. This episode of QD Clinic is about stopping meds. Yesterday was a bizarre day. Yesterday I had two patients back to back come in, both with the same story. I stopped my meds, I'm a mess. It was really kind of odd. They had many similarities. Both of them were sort of marginally controlled on a biologic and a DMARD. Had some element of secondary fibromyalgia that always complicated the pain story. But both of them stopped their medicine. The RA patient ran out of Enbrel 3 months ago. He turned 65, was going to go on Medicare, stopped the etanercept and didn't start anything else. And as you would imagine, over the course of 3 months, his CDI, the Clinical Disease Activity Index, went from 10, 12, 13, something like that, to 31. Now with 12 swollen joints, PIPs, MCPs, MTPs, ankle, knee. Truly a mess. Not on any DMARD, not on any biologic. The second one was a psoriatic arthritis patient who lost her insurance because her husband was laid off with COVID, and for 4 months has been taking nothing. And she was on a lot of medicines for a lot of things, so it wasn't just her arthritis that was affected here. And she's a gigantic mess. She went from a CDI of 9 to a CDI of 55. Hello. That's about the upper limit of what you can actually get in a CDI. So I think first off, I'd like to make the point that if you see a patient with a rapid 3, CDI, SDI, or GAS score that's over 30, the patient always has fibromyalgia. It's always the thing that amplifies the numbers to that extreme number. Now they can have, as that 55 patient with psoriatic arthritis, can have rip-roaring synovitis too. But on the basis of just synovitis and some pain and functional implications, it might have been half that number. But add in fibromyalgia, which was present in both patients, it amplifies the numbers significantly. So you should always think fibromyalgia when you see a metric that's 30 and higher. So the question on these two patients is, one, how do you recapture disease control? And two, how do you prevent this from ever happening again? So recapturing disease control, actually not all that hard. It's sort of like the 3 S's. Use the same drug, use drug samples, use steroids. The recent study at ACR by Jeff Curtis looked at what happens when you stop Enbrel or methotrexate and restart them, and they showed that upon restarting that, the patients, 85% of patients recaptured low disease activity state, and nearly 85% recaptured remission numbers, and they were in remission in the beginning of the study, and nearly 100%, 95+%, captured a low disease activity state, suggesting it's really not that hard. And using back the same medicine that was once working is a smart thing. Steroids as bridge therapy, temporizing therapy, and samples are ways to go. I think the important thing here is if you can't use the same therapy and you can't use steroids, you need to then rely on drugs that work fast. What drugs work the fastest? Steroids, JAK inhibitors, and this is the order in which I think they work fast. Steroids, hours to days. JAKs, days to weeks, like 2 weeks. TNF inhibitors could be first shot, could be second shot, then followed by abatacept and the IL-6 inhibitors, then followed by a few weeks to a few months by rituximab, and then your DMARDs, methotrexate, Arava, hydroxychloroquine, sulfasalazine, gold, taking forever. So use the drugs that work fast, even if it's only to use them for a short period of time. Who's to say you can't use a biologic instead of a steroid in people who can't take steroids? Brittle diabetics, people who can't tolerate steroids. Who's to say you can't use a short burst of Kineret like you would for acute gout, or even a short course of a weekly or bi-weekly TNF inhibitor given weekly for 3 or 4 doses while you're doing some other measure. I've done it. It actually works. Recognize that it's not just inflammation, it's also pain. It can be mechanical. So do the measures that need to be done to control pain: bed rest, immobilization, splinting. I always say, and get in a lot of trouble for saying, PTOT, chiropractic, is what you do while the patient's waiting to get better. Now, those things do work. They're proven to work, and I'm disrespecting them by what I'm saying, but in fact, that's often the case. They are temporizing measures to keep the patient busy. And then you can say the same for your voodoo joint injections. We all love our joint injections. We think we're the best, but the fact is, long-term data isn't very good about joint injections with steroids. Short-term, we know that they work well. So these are things you do to can recapture control. What can you do to prevent cessation flares? Number one, plan. If they're 65, you got to ask them, what are you doing with your insurance at the turn of the century here? What happens when you go on Medicare? Let's have a plan for a succession off of what you're on and what you can be on during Medicare. You should probably be asking annually. Pick a date that works for you. Make it tax day, make it their birthday, make it Christmas, that you're always going to ask about who pays for your medicines. What's the status of your insurance? Let's look ahead for the next year. Like, why not have, New Year's resolutions with patients and discuss especially the money aspect. When they ain't got the money, they don't have the meds. When they don't have the meds, you become more important, but there's less you can do. It gets really complicated. So I guess the important thing is to let you be in the driver's seat. Let them know that you're the boss, you're the gatekeeper when it comes to taking medicine, staying on medicines. Relying on other people or relying on their own judgment, bad idea. Most importantly, preach consistency. I tell my patients the goal is being boring. Boring to the point that you do the same thing the same way. Take the same medicine, same diet, same exercise, same plaid flannel shirt, whatever it takes to be consistent, because when they get out of consistency, sudden death in the family, they got to go to Cleveland, they leave their medicines behind, they stop sleeping well, they stop exercising, they stop eating right, they go to hell in a handbasket right quick, as we say here in Texas. So when the going gets rough, the tough double down on being boring and consistent. This is what you have to preach. Tell them they cannot get out of the habit. The habit is what got them there. It's not just one drug, not just that magical JAK inhibitor or IL-6 inhibitor you gave them. It really is the whole package of what you do. That's it on how to avoid and treat cessation flares. Again, remember, Room Now Live. I think it's going to be a great hybrid meeting. Room Now Live was the original and the best of hybrid meetings, meaning a live meeting or a streaming internet meeting. You can choose. We'll see you there.